Well, good morning, everybody. Let's go ahead and get started today. We have Dr. Stephen Morrow giving us a presentation on delirium and in the hospice patients and population. I'll turn it over to him and he can get started and yeah, enjoy the lecture.
Thank you, Dr. Phillips. Steve Morrow here. Hopefully everybody can hear me without echoes. Really just a privilege to be here with you all this morning. I wanted to talk about delirium and from kind of a hospice and palliative care informed approach. Let's see if I can advance my slides. No conflicts of interest. Lots of work cited in this. This is me, a decade and a half ago. And just wanted to say that I come by this lecture honestly through about 15 years of work, both as a hospitalist on the inpatient side, seeing patients who are at high risk for delirium, and therefore we frequently see it. And then in the latter half of my career, going through this fellowship that many of the fellows are sitting in now, and eventually for the past 2.5 years, doing palliative care on the inpatient side in Kalamazoo, and dealing with a lot of acute delirium, thinking about it from a little bit wider lens and view as a palliative care physician. And you know, just thinking about and reflecting on 15 years of doing this, and it's changed the way I view about a lot of disease processes. And initially when you're early in your career, you think about the pathophys, you think about the biochemistry, and as you see a lot of disease in the wild, you really start to think about how it affects your patients and your patient populations as a whole, and think about all of us, how we can do a better job diagnosing and treating these disease processes in an equitable and a humane way. The learning objectives for today, we want to try to provide a working definition for delirium. And we want to make sure that definition is well differentiated by one of its closest mimics in the wild, which is dementia. And this is often a conundrum that the palliative care doctor and the hospitalist will face, especially as we navigate these discussions with family. Is this delirium, or is this dementia, or is it both? We want to delineate palliative care informed assessment and evaluation of patients with suspected delirium. We want to weigh the evidence backing pharmacologic and, importantly, non-pharmacologic interventions for acute delirium. And then I want to spend a little time discussing the wider implications of delirium management in 21st century American healthcare as sort of a test case for a lot of what we do in healthcare these days, including looking at demographic trends, potentials for inequities, burdens to our healthcare system as a whole, and public perception of an aging population. When we think about defining delirium, the gold standard remains the DSM-5, which talks about disturbances in attention and awareness. Importantly, this includes reduced ability to direct focus and sustain attention, along with reduced orientation to the environment. And importantly, this usually plays out over a short period of time. Acute delirium, usually hours to days, tends to fluctuate throughout the day. And that acute and fluctuating trajectory is what often differentiates it from other disease processes such as dementia. There's usually disturbances in cognition, which can include memory deficits, disorientation, language disturbances, or even alterations of consciousness and differences in perceiving reality. It's like a lot of DSM criteria, not better explained by other conditions, as a nice little wastebasket term. And we want to find direct evidence of a physiologic cause if possible. The DSM-5 definition is helpful for clinicians, but as palliative care physicians, we often are seeking a more common language definition as we discuss this with our patients and our families. And so I like some more simplified and understandable language, such as delirium being a sudden change in a person's thinking and attention, leading them to become confused. And I think this language can be more understandable for our patients and their families. But as we work through a common scenario where in the hospital or perhaps in the hospice setting, I have less experience with hospice than many of you. And so my bent tends to be more in the acute hospital setting. But I want to be cognizant of my colleagues on this call that do a lot of hospice work. As we deal with patients in a decompensated setting in the hospital, or perhaps encounter patients that are somewhat decompensated in hospice. And we're trying to make an assessment. Is this change in cognition that we're seeing reflective of an acute sudden change, or is this a culmination of a more long-term process? We're really trying to make the distinction often between delirium and dementia, both in terms of how we might intervene for interventions, but also how we describe the prognosis of these two processes to families, and perhaps even consider eligibility for hospice enrollment or other important aspects of our work. So this is a good table that differentiates some of the clinical features of delirium as opposed to dementia. And I've sort of highlighted the important things that we consider as we entertain this differential diagnosis. The biggest one being reversibility, because that speaks to how we speak to families about the future and how we prognosticate about this particular patient. Whereas delirium is usually reversible, dementia is often irreversible and progressive. And that's something that's easy to say in hindsight, but when we're in the thick of the differential process, we don't have the benefit of looking forward to the future. So as we try to predict reversibility, we use the other highlighted features in this slide to try to differentiate. Delirium usually having an abrupt or subacute onset, whereas dementia is more insidious in trajectory. Delirium often impairs attention. The patients have a difficulty maintaining attention and focus, whereas that is usually only a feature of the latter stages of dementia. Consciousness fluctuates or is impaired with dementia, whereas usually consciousness is maintained much more significantly through the process of dementia until the very, very late stages, or perhaps in some of the alternative non-Alzheimer's types of dementia, such as Lewy bodies dementia in its terminal stages. Speech is an important clue when we differentiate delirium from dementia, whereas in delirium, speech often becomes incoherent and nonsensical. In dementia, often it is more of a paucity of speech, and they have word-finding difficulty and lack of fluency as opposed to incoherence. And that kind of relates closely to thought processes. Delirium tends to be disorganized thought processes, whereas dementia is really just more of an impoverished situation where there is decreased overall thought process. And through an understanding of the clinical trajectory, we can try to differentiate delirium and dementia so that we can prognosticate for families, understanding that there's often quite a bit of overlap with these two. The thing to remember is that when we think about the risk factors for delirium, who are the patients that tend to become delirious more easily? Dementia itself is one of the independent risk factors. And that speaks to the overlap of these two processes and why it is sometimes very difficult to differentiate, because often the answer is and not or. Other risk factors for delirium include any other cognitive impairment, not only pre-existing dementia, but other cognitive disorders. Age is an independent risk factor, especially over the age of 65, which is, we can all imagine, is the majority of our patient population. Patients with multiple medical comorbidities, patients with a history of institutionalization, infections, polypharmacy becomes a big risk factor as patients navigate our American healthcare system. Postoperative states and any version of sensory impairment, including hearing or vision impairment, increases our risk factors. So it's important to consider those, both as we consider our own patient population and as we think of population health and trying to minimize the risk of delirium. Unfortunately, Those efforts to minimize the risk have not been entirely effective across our nation and our healthcare system. Prevalence still remains high. And in fact, prevalence is probably higher than we realize. The diagnosis of delirium is probably under recognized. Studies are difficult and vary widely, likely due to different assessment criteria and slightly different and nuanced working definitions of what actually includes a diagnosis of delirium. But several studies include 28, a range between 28 and 83% of patients at end of life, probably, in my opinion, trending towards the higher end of that spectrum. A significant portion, between 11 and 42%, depending on the study, of patients in the hospital, and up to up to three-quarters of patients in the ICU experience delirium at some point in their clinical course. It's also quite common after both elective surgeries and especially high-risk surgeries such as vascular surgery or neurosurgery. Um, Delirium is a process that we're seeing and probably under-recognizing quite commonly. I have not been able to find, and I don't think there is any evidence that the incidence of delirium is increasing or decreasing over time within our national population. It would be interesting to see if COVID made a change, but I've looked at several studies that suggested that overall the incidence of delirium is not changing over time. Um, When we think about differentiating delirium from dementia, when we think about the risk factors that lead to delirium, and when we think about the incidence of delirium in our patient population, these are all important academic exercises because delirium has significant effects on our patients. It is not just an academic pursuit to think about delirium. Delirium is destructive. It's associated with a significant mortality risk in our hospitalized patients. Um, Up to twice as likely to die in the hospital if they have a comorbid diagnosis of delirium. And that probably is associated with many of the morbidities that accompany acute delirium. Um, and there are a number of studies highlighting each of these comorbidities, each of these morbidities associated with delirium. Increased falls, increased incidence of pressure ulcers, increased incidence of infection, increased healthcare cost and length of stay, both in the hospital and the ICU, risk of long-term cognitive impairment. As much as we talk about delirium being an acute and reversible process, maybe not causative, but correlated with long-term cognitive impairment and long-term need for institutionalization and long-term care. So I think it's fairly easy and rational to think about delirium causing these things. Patients that are delirious and less participatory with their care would be at higher risk for things like getting inadequate nutrition, leading to pressure ulcers, falling more often. We can sort of make the cognitive association here, why delirium can lead to morbidity and mortality. But I think it's always important to remember this slide. Sometimes delirium is sort of viewed as an inconvenience to us as providers and to the healthcare system. It is both risky and, in fact, deadly to our patients. It's also, I think, important to recognize the following concept that goes under-recognized, in my opinion, quite often. There are several types of delirium, the most common type actually being hypoactive delirium. But the type that seems to be talked about or thought about most commonly is hyperactive delirium. Hyperactive having characteristics of increased motor activity, restlessness, agitation, aggressiveness, wandering, hyperalertness, hallucinations, delusions, right? And these are the patients that get the most attention. They're the most obvious. They're the ones that the nurses paid you on. And they represent a minority of delirium cases, a 23% in the most common study. The more common type is actually hypoactive delirium, and it's probably the less recognized type because they don't make as much trouble, honestly, for all of us. Hypoactive delirium is characterized by symptoms of drowsiness, inactivity, lethargy, psychomotor retardation, reduced alertness, And frankly, sometimes the nurses describe these as easy patients. That doesn't decrease their morbidity, mortality, or the risk to their clinical course by their delirium. And it doesn't negate the need to screen, diagnose, and treat this type of delirium. Also interesting is there is a version of mixed delirium where patients alternate between these two versions of delirium. And in fact, I think that a lot of the quote unquote treatment for delirium is essentially shifting patients that present in a hyperactive state that is difficult to manage and perhaps unsafe, trying to actually just shift them to a different type of delirium, shift them to a more hypoactive delirium state where they're more manageable. Unfortunately, that's necessary sometimes to reduce or to improve patient safety and to align with goals of care for families, but it doesn't resolve the underlying delirium issue. Delirium is best thought about from an intervention point of view and a prevention mindset. We think about how can we prevent delirium from occurring in the first place. This will be important later when we talk about treatment. But a lot of societies have talked about various interventions to prevent delirium. We want to maintain orientation by frequently reorienting to time, place, location. This is a lot of when you see the signs on patients' walls, and making sure that a clock is readily available. Also orienting them to date and location frequently. We want to try to create a calm environment with reduced noise, reduced stimulation, limited visitors, especially unfamiliar visitors. Sometimes one or two familiar faces can actually be orienting. But calm environments are sometimes hard to come by in the hospital world. Probably better in hospice, but this can be a challenge for those of us in acute care hospitals. We want to remember and promote good sleep hygiene, including minimize nighttime interruptions and promote daytime activity. Sleep hygiene interventions are incredibly effective in hospital settings to decrease delirium incidence, but they are also hard to come by sometimes. We want to ensure proper hydration and nutrition. Dehydration is a very important cause of delirium and should be thought about. Early mobilization, recognizing how disoriented it is to be restricted to a hospital bed, whether forcibly by restraints or just practically by disease processes. Also, remember all the lines you have in patients, including IVs, catheters, feeding tubes. All of these things restrict and therefore promote delirium. We want to think about our medicines, especially as we are physicians and APPs. A lot of what we do is prescribing and avoiding polypharmacy, and especially some of the more offensive medications can go a long way to preventing delirium. Addressing sensory impairment, sometimes it's as simple as getting their hearing aids back in, but making sure that they have access to their hearing and vision assistance, and then family involvement as a source of reorientation and anchoring of their cognitive processes is very important in all healthcare settings. So if you have done everything you can to prevent, but you still suspect delirium, what do you do? As a palliative care physician or a hospice physician, I think it's always important to start with a conversation about goals of care, if possible. Sometimes delirium is an emergency. Sometimes, especially when safety concerns are risen, it's an emergency. But as much as possible, we want to pause for a second and think about the situation and the goals of care for this family. I think we can all imagine situations, perhaps on hospice, where acute management of delirium is very important. The goals of care are comfort, and family comfort is sometimes as important as patient comfort. And so acute pharmacologic management of delirium would be very appropriate at end of life. There are other situations where the family is still very much in a disease-oriented and longevity trajectory where they are trying to fix problems and promote longevity. And sometimes the more pharmacologic, aggressive managements of delirium are less appropriate. And we want to think more long-term about non-pharmacologic interventions and how to promote longevity. And so it is always important to try to understand the patient and the family goals of care. I love this slide. Way back in fellowship, got introduced to the concept of building a house by starting with that foundational relationship with the family. The parallel walls of my medical knowledge and coming to best understand the medical story of the biology and the pathophysiology of what's happening to this delirious patient, but also equally important, the patient story, how they got there, what's important to them, what's important to their family. And then together coming based on those two pillars of information, a medical recommendation and a collaborative path forward with shared decision making about how we manage acute delirium. Um, but the first thing to do is think about, okay, if my patient is delirious and I want to address it because the family thinks that that's important for their goals of care, what contributed to it, and what is the specific disease process that's causing it, and is that something that I can address? As a physician, I've always tried to keep my friend Steve Urkel in mind here. Did I do this to my patient? Is always a good place to start. So we think about recent changes in medications or situations that perhaps we as the healthcare team did. Did we start something anticholinergic or opiate or NSAID or sedative, steroids, antidepressants, antibiotics, especially the fluoroquinolones, but even the beta-lactams? Do we start cardiac meds such as digoxin, GI meds such as the dopamine agonist, metoclopramide? Anti-seizure medications are very common. Did we start something recently that caused this? Alternatively, did we stop something recently and they're withdrawing from something? And perhaps that's an easy shift or an easy change we can make to address their delirium. Are there other things that are easy for us to address? Constipation, urinary retention being very common. Sometimes delirium is very abruptly cured with a Foley catheter or a good bowel clean out. Pain is another issue. I've had a lot of my hospitalist colleagues tell me they don't want to start opiates because they don't want to make their delirious patient more delirious. And sometimes it's the exact opposite that's true. Untreated or uncontrolled pain in a hospital setting can be very delirium invoking. And sometimes a little bit of pain control goes a long way to reducing somebody's distress and therefore their delirium. We want to think about easily reversible electrolyte situations, anemias, infections that can be easily treated. Dehydration can be a big one. Is there ways that we can remobilize our patients? Are they depressed or socially isolated? Do they have vision or hearing impairment? As I said earlier, sometimes it's as simple as hearing aids or glasses. Is there emotional or existential distress that can be maybe not easily addressed, but addressed? Or is there an unfamiliar environment that we can resolve by getting them to a more familiar environment? Did they change rooms recently? Would they actually be better off in a home environment? These are all the kind of reversible things we want to be thinking about before we jump to medications right away. In the hospital, I do see the big delirium medical workup often that includes CT scans looking for strokes or tumors, the big lab workup that includes thiamine and ammonia and electrolyte panels. And sometimes this is appropriate. The yield on these tends to be lower, in my opinion, than some of the more reversible and treatable causes. But depending on goals of care, a rather extensive fishing expedition may be appropriate or may be less appropriate, as the case may be. And that's where I think a good palliative care relationship with families and discussion about goals of care can be important about how thoroughly we pursue a broad medical workup for acute delirium, looking for potentially reversible but maybe less treatable causes. Just kind of a side note on the medication things, I'm sure many of you are aware of this, but the American Geriatric Society for a long time now, many decades, has produced a list of medications that are concerning for perpetuating delirium in the elderly population. This is known as the Beers list or Beers criteria. And there's a lot to be said. There's other lectures, and you guys have heard about this, but polypharmacy and deprescribing, and a real attention to medications that promote delirium in our elderly population, and sometimes de-escalating and deprescribing complex medication regimens are responsible for what many of us have seen as the hospice rally. When we start focusing on symptoms and deprescribing, many of our patients actually do better, and this is a big cause. Um, so, and thinking about medications and the rest of the workup, I think a description of a thorough workup for delirium is a little bit beyond the scope of this lecture, but I would ask the fellows and the rest of us in palliative care to really be intentional and nuanced about our workup and being collaborative with families about their goals of care, and how we work up delirium and how we treat it. Because other than finding reversible causes, things that we have done and things that we can reverse from the healthcare point of view, the mainstay of treatment remains very similar to the things we talked about a few slides ago with prevention, right? So the things that prevent delirium are often the things that help to resolve it. Just to review, maintaining orientation, creating that calm environment, promoting sleep hygiene, trying to restore a day-night sleep cycle can be very important for treating acute delirium. Ensuring proper hydration and nutrition, mobilizing our patients, and minimizing restraints and lines. We talked a little bit about managing their medication, addressing their sensory impairment, and involving family in their care. These are not only preventative strategies, but they're treatment strategies as well. We talk a lot about non-pharmacologic interventions, including redirection. Redirection, when a patient is delirious and they're having difficulty with cognitive processing and with anchoring their thoughts and their orientation, sometimes we're tempted to try to fix the problem by telling them where they're wrong. And from experience and from learning, that does not work. You're trying to fix a physiologic process with logic. If you have young kids, you know that the prefrontal cortex is very important in how somebody takes your advice. So, the advice is to try to redirect them to less distressing or less problematic thought processes. If they're going on things that are distressing to them or distressing to the medical team, you try to reorient them back to, redirect them back to things that are less distressing, perhaps what they want to eat, perhaps, something that's in the room that could be interesting. This is when we get into like these sort of fidget things. A lot of our hospital systems have sort of dementia related fidget toys where they can work on buttons or straps or whatever. And you really just try to get them to think about or talk about other things when their delirium has caused them to go to a place that's distressing for them or aggressive or violent or unsafe. Obviously, this only gets you so far. Redirection can be helpful, but is not as strong as some other interventions. And so when you've done everything you can, when you've looked at the causes and tried to address any reversible or treatable cause of their delirium, when you've done all of the things to try to prevent delirium, and once delirium has occurred, you've thought about all your non-pharmacologic interventions, and you've tried to redirect their thought processes in a helpful way as much as possible, but you still have a situation where things are unsafe or are not aligning with goals of care due to distress. Delirium can be a deeply dehumanizing and depersonalizing process. Patients are not, who they are, and can be violent or aggressive. It becomes a more urgent situation, and oftentimes goals of care will suggest or mandate that we use pharmacologic interventions. The most commonly used are the typical antipsychotics. First generation haloperidol is probably the most commonly used. And I will admit that in my training, I kind of grew up thinking because of how commonly this was used, that there must be really good evidence for it. Otherwise, why would we be doing it, right? And that's actually not the case. It's important to recognize something that I was mistaken about for a long time in my career, which is that haloperidol or other first generation antipsychotics do not there's no evidence that they shorten the course of delirium. They don't make people better faster. What they probably do is shift them a little bit from that hyperactive delirium to the hypoactive version. And the good thing about them, if you want to say that, is they probably don't worsen the delirium or lengthen the duration of delirium. They're not a bad thing in that regard, but they're also don't shorten the course. They probably make the symptoms more manageable. Sometimes that is the goal, right? But because of this, and because of many studies that have suggested they don't shorten the duration, uh, the use of first generation antipsychotics have not made it onto any of the guidelines for the management of acute delirium. And so really they should be thought about carefully and used sparingly, and in situations where they are absolutely necessary. It's important to know that general use of them as a routine, especially in non-hospital settings such as nursing homes, has been associated with an increased mortality of those patients. And that has caused the black box warning for haloperidol in elderly patients. Again, that should not preclude you from using Haldol in select circumstances where safety or goals of care align with this. But it's important to realize the lack of evidence and the care and attention that these particular medications warrant for the use of acute delirium. We have also recently found some success with atypical antipsychotics, including olanzapine and risperidol. Similar to Haldol, they do not shorten the course, but they may make symptoms more manageable, and that may align with goals of care. Um, Benzodiazepines are also, in my experience, frequently used for acute delirium, especially hyperactive delirium. The evidence for this is even less so than the antipsychotics. In fact, there's some pretty good evidence that the benzodiazepines can actually lengthen the course of acute delirium and perhaps make it worse overall. And so these should be used very sparingly for situations where safety or suffering related to acute hyperactive delirium is very severe. Um, they are certainly do not appear on any guidelines for the management of delirium. And while they can sedate patients and eliminate the worst of behaviors, they can be disorienting and delirium inducing on their own right. So benzodiazepines very sparingly for this. Because of the lack of an effective delirium treating medication, a lot of smart people have looked at a lot of chemicals and said, is there anything else out there that helps? I think one of the emerging pharmacologic interventions that's getting a lot of attention recently is dexmedetomidine. Wow, I actually pronounced that correctly. I think maybe they gave it the name Precedex for a reason. This is an alpha agonist that's generally given as an infusion and may have a similar role to the antipsychotics in that less likely to worsen acute delirium and may have a role in managing symptoms of hyperactive delirium without making the situation worse. Does it improve delirium? Evidence is still kind of not available for that. And so I personally view this as kind of a similar to the antipsychotics, that it can have a role in managing behaviors and symptoms, but probably does not shorten the duration itself. A lot of research and investigating cholinesterase inhibitors, which are used for dementia and can sometimes actually make delirium worse. Melatonin and melatonin receptor agonists, again, some thought about restoring sleep-wake cycle and actually preventing delirium. Mixed reviews on this. There was some excitement earlier on, and I think some of that hasn't panned out for melatonin and melatonin receptor agonists being a preventative. There's some work on statins being preventative over many years and decades as a way of preventing neurovascular damage in the brain. Not great evidence for that either. People have tried propofol or ketamine, and also just empiric opiates. I have to say I have used number 6 a number of times when I'm not sure what's going on, but the patient would have a physiologic process that's painful, and I am not entirely sure that they're not painful. Sometimes a trial of opiates at relatively conservative doses can be helpful to see if pain is a contributing factor to their acute delirium, and I have had some success with that. Um, There's a special concept that a lot of us think about in hospice and palliative care at end of life, which is this concept of terminal delirium. Um, this may be a separate process, depending on who you talk to, or it may be delirium associated with a brain that is shutting down. Some people will suggest that this is a natural or important process for patients to go through and represents psychological or spiritual processing before death, and that's fair to consider. It lends itself to a somewhat nuanced discussion about how should it be managed and treated. Is it something that we should try to mask or treat, or is it something that patients need to go through before they die? And I'm not smart enough to maybe know the answer to that, but I would certainly suggest that, like a lot of things, we start with goals of care and conversations with our family about what's important to them. For a lot of families, this terminal delirium can be particularly distressing, and if there's a perception that it's distressing to patients, it would be, in my opinion, appropriate to manage it the same way we discussed earlier with managing hyperactive delirium, by trying to shift that to a more hypoactive phase with some typical antipsychotics. Um, for other families, it is important that their loved one have a natural death and be able to process things. And that's fair as long as it's safe to the patient and that we feel that the patient, to our best assessment, is not undergoing significant suffering. Um, so let's see, it's 8:07. I want to spend a little time thinking about delirium because it was just as a, maybe I shouldn't say this, but as an aside, I was asked to do a delirium lecture a couple of years ago, and I said, "Why? I haven't really. I'm not a delirium expert. There's actually, I think, some neurologists on this call, which always makes me a little nervous. But delirium isn't really my forte." And then, as I was thinking about the creating the lecture a couple of years ago, really started thinking about it in a wider context. And as a hospitalist and as a palliative care doctor, yes, I mean, delirium is absolutely something that I've dealt with a lot. And the more I think about it, the more I see delirium as a very important representation of healthcare in general, and speaks to some of the issues that our healthcare system and our palliative care field faces as we look into the middle and the latter half of the 21st century. And there's some important features about delirium that I think are worth lifting up in this discussion. Um, One of which is delirium, like any other disease process, can run the risk of having the patients that suffer from it uh, develop inequities or inefficiencies in how it's screened for, how it's diagnosed, and how it's managed. Especially because the risk factors for delirium involve members of socioeconomic groups and of social cultural groups that are can be historically marginalized. So, one of the big things is age, right? Delirium tends to have a predilection for folks that are older, and that runs the risk of ageism. However, there are also some studies that suggest that women and members of lower socioeconomic groups have less access to delirium screening and interventions. There can be cultural barriers and language barriers that impede the effectiveness of delirium screening. One of the things that can be really orienting for patients and families is their language. And when there are language barriers in the healthcare system, that is an independent risk factor for the development of acute delirium. Delirium patients, kind of almost by definition, they lack capacity, they lack agency, and they can be a highly vulnerable and marginalized group. And so when you think of delirious patients as a population group, I think they are at risk for being under recognized, under treated, under advocated for. Um, Related to that, delirium is sometimes viewed as an orphan disease. It doesn't necessarily have a specific medical subspecialty taking ownership of it, the way that heart failure would have cardiology, or even dementia often falls more into the neurology or neuropsych disease specialty. So sort of who owns delirium, right? Is it geriatrics? Is it hospital medicine? Is it palliative care? There is, interestingly, an American Delirium Society. They hold annual conferences. But I do personally worry that this is a disease process that's often under advocated for. And when we think about delirium in the healthcare system in the 21st century, I think it's important to recognize that this could be a very high risk and important disease process for us to manage in the future, right? So if we pause for a second and think about what we're facing as a nation and as a healthcare system, I think a lot of us have thought about these things before in palliative care, but our patient population in this country is getting older. The graph on the left shows in blue the percentage of the population that's 65 or older. And then, the younger population, which this is 18 and under in the pink, but I would also include maybe like 40 and under, thinking about the healthcare workforce that needs to treat 65 these patients that are older. We're entering into a phase there's more sick patients, there's more patients with multiple comorbidities, including delirium, and there's less young people to take care of them. This is a demography slide that sort of shows the US population from 1910 to the current day. And in the old days, I shouldn't say that way, in the earlier part of the 20th century, it looks more like a pyramid. There's a very small percentage of patients at the top that are older and a very large workforce, this kind of bulge coming through here in the 50s is the baby boomers. These are now becoming our older patients that are more at risk for delirium. And the amount of workforce, which is all of us at the bottom that are going to care for them, is as a ratio, lower and so less resource to manage all disease processes, yes, but especially a disease process like delirium, which has a predilection for the elderly and the patients with multiple comorbidities. The amount of comorbidities that our patients have in general is increasing, including delirium. And delirium overlaps with a lot of processes that I think we see increasing in frequency across our nation, including clinical depression, dementia, and social isolation. So in some ways, it does sort of serve as a test case, a particular disease process that I think is important as we think about how our healthcare system and how our field of palliative care responds to the challenges of the 21st century. Healthcare is increasingly for profit and getting bulky in terms of administrators and non-physician, non-APP providers. And so delirium serves as a disease process that we have to be careful about how it progresses into the 21st century, into a healthcare system that is increasingly strained. Traditional treatment for delirium, as we discussed, has kind of been about chemically shifting hyperactive delirium to hypoactive delirium so that it can become more manageable for us as a healthcare system. It's kind of easier for us, but may not always be what's best for the patient. I would argue the true answer for delirium is not a medication or a drug. It requires prevention, screening, and non-pharmacological interventions that require significant caregiver time and effort. And our system is not always good about that, and probably will become increasingly strained for caregiver time and effort as we move forward. Relatedly, a lot of that time and effort is shifting onto families and non-medical providers, and that's leading to caregiver burnout. Delirium can be exceptionally fatiguing to non-healthcare providers, and it can be a significant cause for caregiver burnout. Delirium costs the system, it costs the patient, and the easiest solution may not always be the best. And delirium, with its predilection for the aged, the medically complex, the culturally marginalized, disproportionately affects patients who are vulnerable and almost by definition can't advocate for themselves. So, and it's also something that I think we've all seen this. When a loved one is delirious, it touches something I think deeply human about our patients and threatens their humanity and their personalization in a way that's very challenging for families. I'm often find myself telling families sort of overtly, I know that there's somebody else in there. I know that you've known a person for many decades that looks very different from this person that's strapped to the bed taking swings at my nurses. I want to remind my families that I recognize that. Sometimes I've never actually met that sweet individual that lived for 60 years and raised a family and coached a baseball team. All I've ever seen is the guy trying to, take my nurse's head off. But I think it's important to remember and to recognize and to remind our families that we appreciate dementia can be depersonalizing and dehumanizing, and because of that, the way we manage it, the way we manage it in a strained healthcare system, I think is really important. And the disease process itself kind of serves as a canary in the coal mine for how we're going to deal with other disease processes, such as dementia, such as cancer, such as renal failure, in this new 21st century of healthcare. And I think that palliative care has a huge role in advocating for humanistic and intentional management of all these disease processes, but especially a disease process like delirium that affects the aged and the marginalized. So, to the fellows, particular, I think palliative care has a unique role in how we manage this, and I would ask you to be intentional about when you approach a delirious patient and taking your time with it. So, as a reflection of all of this, a couple of quick practice questions. We had a bit of a discussion the last time I did this, so we'll see how it goes. While on cross coverage for the inpatient palliative care service, you are called urgently to bedside for an 82-year-old male who is crying out repeatedly, "Mabel, and help me." He appears agitated and scared and occasionally tries to slap the bedside nurse. His granddaughter is nearby and expresses concern because earlier this morning, the patient was calm, cooperative, and reminiscing about his deceased wife, Mabel, and how the medical team's new anti-emetic plan was certain to cure his longstanding cancer-associated nausea. So what's the next best step? Some hints in there, right? I mean, this guy is obviously delirious. He's agitated. It's becoming an unsafe situation because he's trying to strike your nurse. Maybe we changed some medications recently to try to address his nausea. This, of course, is usually happening like late afternoon or early evening in a sundowner situation. And the granddaughter is at the bedside and super distressed about this whole thing. So there's a number of choices: 5 milligrams of IM Haldol, 1 milligram of IV Haldol, 2 milligrams of IV Ativan, 50 milligrams of IV Benadryl, soft limb restraints, reinforcing sleep hygiene measures, a thorough workup for causes of acute delirium, or efficiently clarifying goals of care with appropriate surrogates. Any thoughts about next steps in this particular case? I always get a little nervous about throwing it out to the floor, but I don't know. The Trinity folks look wide awake, so somebody's going to chime in.
Yeah, he was nauseated, so I don't know what his electrolyte status is. Secondly, he introduced anti-nausea drugs. I don't know which ones they are, but they could be culprits. And somewhere in there, I can't read that slide very well, but goals of care, I don't really understand in this patient. So it start with a granddaughter and flip through the chart and see if I can find any clues. After that, I don't, we can always, if he's really off the wall, I mean, Haldol, as you say, will control these behaviors. And if it is that bad, you can take it away once you find, you can do many things at one time. Um, but it does sort of depend on what I see when I walk through the door.
Yeah, I think that's a great answer. Any other thoughts or considerations before I ramble some
I
more?
mean, I'd say I would, coming from my ER background, and with an elderly person, I would say soft restraints followed by Haldol, unless you have a Haldol blow dart, which is probably going to be too much for him. So I would say to get his safety should be the primary since he's swinging, and soft restraints could be pretty um, well tolerated initially. But I mean, you can't leave someone in soft restraints because they'll end up, you know, in rhabdo or something, but get him controlled, and then, we don't know if he has an IV or not, but followed by a low dose Haldol, I think would make sense.
Yeah, I love that. I'm not sure there's a right answer. I put answer B, 1 milligram of IV Haldol, as the quote unquote right answer, because that's what we agreed on, I think, last year. But last year I had H as the correct answer. So I think this is the whole thing is just kind of to promote discussion, to be honest. I think you're very right to suggest that safety is probably first here, and if we're trying to hit nurses, and this was kind of the discussion like 2 years ago, like if we're trying to hit
That's on
nurses,
the nurse,
the
doesn't it?
daughter is distressed, and I probably should add into the question stem now that I've had that suggestion. Yes, we have IV access. Let's just say that's true. Then it probably makes sense to try to get safety addressed first in this situation. But I love the discussion, and I love the idea that like if we can avoid it, like maybe we shouldn't be restraining or giving chemicals restraints, and maybe that's just not avoidable in this case, right? If we have time and we can efficiently get more information about what the goals of care. This guy may be headed off to hospice tomorrow with some horrible cancer. And look, we just need to get through the night. I'm not looking for any kind of long-term success here. I just want him to sleep tonight. And, a big dose of Haldol, and then we wake up tomorrow at home, may be the goal, right? But sometimes you don't have time to have those discussions before he slaps the nurse. I think soft limb restraints, if we can avoid physical restraints in general, that's usually best. And sometimes that is just necessary. Um, I think sleep hygiene is a great idea. Maybe a little too late for that right now. Thorough workup for causes of delirium. Again, goals of care. Like we may want to go doing brain CTs and a whole lab panel and all that sort of stuff, or we may be headed to hospice tomorrow, and another needle is just not in the cards. I will say that Ativan and Benadryl probably not. You're going to be your first line. You're definitely going to stick with Haldol if you're gonna do a pharmacologic intervention. I would add, olanzapine or Risperdal could be okay too, but that's why they're not on there, because we're just going to stick with one for the question here. And then,
Stephen, I got a comment on this one too. My question when I read this is, what happened between him being calm and cooperative and suddenly swinging at the nurses?
Yeah. So a great medicine review. Maybe we pumped him full of a bunch of Reglan.
That's what I was saying.
And because that was our great plan for his nausea. And so great.
But you
Well,
can't do
I
that.
didn't know. Yeah.
Yeah, like acutely.
So stop that, right? Maybe we ordered some Reglan and metoclopramide, and somebody gave him metformin instead. So the medication error. So definitely a med review. But unfortunately,
You should get the nurse.
once it's in his system,
I might.
yeah, it's hard to get it out. And that kind of highlights just one thing I've learned about test taking, right? Is sometimes like they all look like good answers, and just be really careful with the stem. Sometimes if it says like what is the next best step, they're really thinking for like terms of putting things sequentially. So like a review of medications is definitely on there, but that's maybe not the next step, because it's going to take a while to figure that out and to actually intervene on it. Whereas if he's taking a swing at a nurse, you've got to address safety now. And so I've noticed that on a lot of tests. We're like, oh gosh, these all look like good answers. I don't know. And then I realized they're looking for the next thing.
About that, it just made me think of, do we ever talk about checking blood sugars on these people? I just had like a light bulb moment. Like we talk about things that mimic and the sudden onset, like, people who are hypoglycemic, when you just mentioned, it made the metformin's actually what made me think of it is, someone who's acutely hypoglycemic, easy test, right? Because it's a bedside blood glucose, rather than sending off labs, which can be down the road. But if somebody's acutely hypoglycemic, they can act pretty squirrely.
So yeah, I do find that hypoglycemia kind of has a syndrome associated with it in terms of diaphoresis and decreased mental acuity and tachycardia, et cetera, et cetera. However, you're right, and there's a lot of different electrolyte abnormalities that can contribute. The point of care glucose test being so rapid that is often part of it. But the hypoglycemic patient tends to have a certain kind of syndrome associated with it. But certainly if that falls within goals of care, that can be part of your workup. I do have just a quick question too, which is much less controversial. I think in the setting of acute delirium, there is clear and consistent evidence from clinical trials that first-generation antipsychotics clear cognitive processing and resolve delirium episodes sooner than non-pharmacologic interventions. Is this true or false? False. It's pretty obvious after this talk. However, this is something that I didn't really wrap my head around for, I don't know, the first 8 years of my hospital stay. A hospitalist gig, I would be like, yeah, give him some Risperdal and we'll be cleared up
Which
by
institution?
Don't worry about it. Yeah, we're all good now. We've learned our lessons.
He's doing a lecture from his room.
No, I mean, it wasn't quite that bad, but I think there is a perception that you can fix delirium with meds. Like you just give them some Risperdal and eventually they'll be fine. We can probably manage some of the worst behaviors, but as we sit down and talk with our families about what the future holds and when is this going to get better, unfortunately, like a lot of things in palliative care, there's a lot of gray there. And we have to make decisions in a setting of uncertainty. And we don't always have the greatest interventions for the disease process that's facing their loved one. So that sounds like bread and butter palliative care, right? But yes, unfortunately, there's not great evidence that antipsychotics actually make delirium clear up faster. All right, that's all I got. And I just pause here for any additional questions or thoughts or comments.
Well, first, I want to thank you for doing this. Earlier in the week, I walked into a patient's room in a nursing home. This gentleman had Alzheimer's, but had an acute change. And, my attending that was with me kind of worked through the management of this a little bit like what we just talked about. But I kind of went home and asked all the questions that were on your outline and was going to spend this weekend digging into it. So thank you for taking care of that for me. There's still a lot of digging to do, but this is really helpful.
Well, I just want to add or reemphasize too the easy thing and what insurance covers is medication. Where I think we need more of a system change is within the non-pharmacologic interventions, and how do we get that to be an affordable cost? Because it takes one-to-one sitters. It takes people to be with the person constantly redirecting. In the outpatient setting, we often talk about adult day programs, which can be very helpful to, and this may be more of a dementia when we talk about that, but it's very helpful to get them into an environment where they're socially engaged, oriented, and able to interact. But it's not affordable. It's things that families can't afford to do and insurance won't cover. And so often, maybe more so in the hospital, we're left with those cheap, easy solutions, which are not good long-term solutions.
And even in the hospital, they don't have one-to-ones half the time,
right,
that you need them.
And I think looking back to Monday morning, the thing that talking about that one-to-one, the thing that really struck me in those discussions that came out in this nursing home was the usefulness of the caregivers there. They all came to the table, the person that brought them the food, the nurse that was taking care of them, the housekeeper. All these three people entered into this discussion and were actively involved. And I thought, wow, it's probably unique. And it was probably one of those moments, but it reminds me of how important all of that is.
I'm also curious, in your research and study for this, have you come across anything about AI companions?
Ooh.
Well, that's a great question.
Oh, thank you. Well,
Well, now we've started another 30-minute conversation.
Yes.
I don't know. I haven't. Well, no,
answer your question.
I can't say that I really looked, but that's interesting,
Yeah.
right?
Yeah.
Mhm.
Yeah.
Challenge for next year.
Yeah. Just keep adding to it.
Yeah, yeah.